Good afternoon, everyone. So, I'm Hiruni Nimesha, Senior Registrar in Respiratory Medicine from National Hospital for Respiratory Diseases, Welisara. So, today I'm going to talk about an interesting disease. Actually, it is for the researchers and for the treating physician and the patients would have a nightmare. So, I don't have any disclosures. So, why talk about TB? So, TB remains one of the deadliest infectious diseases even today in the world. And in Sri Lanka, it is the second leading infection after dengue. So if I'm pretty sure that you guys are very familiar with dengue. So up until now in 2024, we have had nearly 40,000 of dengue cases. And from that, we have had 19 deaths. So in dengue, the case fatality rate is 0.05. So what is when we take about TB? In TB, we have around 500, 600 annual deaths in Sri Lanka. Can you believe it? We have highly qualified physicians, first-line drugs, second-line drugs, still we have 500 to 600 annual deaths. And the current TB detection rate in Sri Lanka is 7,000 to 8,000. But according to WHO guidelines, we are supposed to detect 14,000 cases within a year. So we are detecting less. Even for that, we have 500 to 600 cases, deaths in a year. So why not talk about TB? So today's presentation, I'm focusing on lymph node TB, which is the commonest type of extrapulmonary TB and young females. The commonest type is the cervical lymphadenopathy, but it has very few serious differentials. But despite telling it is the commonest of EPTB, only a very few fulfill the typical histological and microbiological evidence. It is difficult to diagnose, difficult to treat, difficult to follow up, and difficult to be declared as cured. So what are we doing? Difficult to treat, difficult to diagnose, difficult to follow up. What is this lymph node TB? So let me take you through a simple case that we have recently got to understand what is this lymph node TB. This is about a 27-year-old female from Jala, married with one child, and she works in apparel industry, lives with an extended family and a compact housing environment. She's presenting to us with gradual enlarging, non-painful swelling of the left side of her neck for 2 weeks duration. There were no lumps elsewhere, no associated fever, night sweats, but she was having a significant loss of weight of 20 kilograms within 6 months and a loss of appetite. So there were no pruritus, abdominal pain. There are no features of connective tissue disorders, no past history of TB, no recurrent respiratory tract infection, or recent sore throats. On examination, she was well built. BMI was 21. She was pale, and there was a 4 into 5 centimeter swelling at the left side of her neck. There were no node cells and lung auscultations were normal. This patient was referred to us from the surgical site. The initial investigation showed an anemia of 7.9 with normal platelets and WBC. Blood picture showed severe anemia with iron deficiency and possible coexisting hemoglobin. ESR was elevated at 70 millimeters per first hour and normal CRP and normal LDH. So ultrasound scan showed multiple enlarged lymph nodes in bilateral level 2, 3, 4, and 5, with the largest lymph node at 1.3 centimeters SAT. It showed fatty hilum alterations and increased vascularity. So ultimately, the diagnosis was given as possible TB infection with multiple enlarged lymph nodes and central necrosis. FNAC showed necrotizing granulomatous lymphadenitis, and excision biopsy showed granulomatous inflammation suggestive of TB. MAN2 was positive at 12 millimeters, chest X-ray was normal, sputum AFB gene expert was negative, UFR, toxo antibodies, EBV normal, liver function tests were negative, and USS abdomen showed no organomegaly, no intra-abdominal lymphadenopathy, or no omental thickening. Retroviral studies were negative, and TB gene expert in the lymph node became positive for Mycobacterium tuberculosis. Rifampicin resistant was not detected. And the TB culture was, again, Mycobacterium tuberculosis positive, sensitive to all first-line drugs. So this is the lymph node histology showing necrotizing granulomatous lymphadenitis with KC18 necrosis and TB culture positivity with 1 to 19 colonies. So what would you do? Young female, neck swelling, lymphadenopathy, positive TB cultures, obviously treated as TB. So we started anti-TB treatment with the fixed drug regimen, HRZD, 3 tablets daily. So in intensive phase for 2 months, and within this phase, there was some improvement in the lymph node sizes according to the patient, which was not radiologically reported. But she was having this persistent loss of weight and loss of appetite. So after this, after 4 months, now she is coming with left side axillary swelling. There was lymph nodes in the in examination. So what would you do? Now the patient was almost confirmed to have TB. Correct treatment was started with good compliance. Now 4 months, she is having another territory involvement. So continue for full 6 months and reassess. Stop all the first line drugs and consider second line treatment. Well, start a treatment regimen or redo all the investigation. Or let's take give a short course of steroids and see if she responds. Or this can't be TB, or look for other differentials. What would you do? Okay, so what we did was we revisited the history. There was no childhood severe reaction to BCG vaccination. There's no recurrent history of respiratory tract, CNS, or recurrent skin sepsis. She has had several blood transfusions during pregnancy, but the cause is not evaluated. No recurrent bleeding or excessive blood loss. Her mother was diagnosed with pulmonary TB during the 2nd month of her treatment, and she had no adverse effect for the ATT, and there were no TB elsewhere that we could find. So we did all the investigations again. The ultrasound scan of the axilla showed multiple enlarged lymph nodes, this time largest 2 centimeters in SAD, and persistent cervical lymphadenopathy with the largest node of 1 centimeter SAD. So with this, we took all the biopsies again, FNAC, and sent for TB PCR and culture. So with that, again, the basic investigation were repeated. Retroviral studies were negative. Fasting blood sugar was normal with VDRL negative, but ESR was persistently elevated at 76. LDH was normal, and remind you that she had necrotizing granulomatous lymphadenitis, and the ANA was negative. Hepatitis B surface antigens were negative. This time also TB culture became as MTB positive, sensitive to all drugs. So we started her on CAT2 treatment or retreatment regimen, if we say it now. So the axillary lymph node biopsy again showed KCS in granulomatous lymphadenitis. Gene expert was positive with low incidence, and rifampicin resistant was indeterminate. So we started the retreatment regimen, intensive phase for 3 months, HREZD, and continuation HRE for 5 months. But with the treatment also, she did not come up with significant improvement of the lymph nodes or the symptoms. So we anyway continue the treatment. Now what is happening? 7 months into treatment, now she's again coming back with breast lumps. So this time she had right breast lump with irregular margin and hypoechogenicity, positive of TB. And in the cervical ultrasound scan, the multiple enlarged lymph node, this time the largest had 1.7 centimeters. So this patient has twice undergone ATT treatment. So this time also, we have to do all the investigations again. FNAC of the breast lump and the axillary lymph node showed caseous granulomatous lymphadenitis, and gene expert confirmed the MTB infection, and the excision lymph node was taken this time for TB culture, and mammogram was arranged. So this is FNAC showing caseous granulomatous nephritis inflammation in breast and also in the lymph node. So persistently fasting blood sugar was normal. HIV studies were negative. Blood picture showed iron deficiency anemia. HPLC was negative. EBV, CMV studies, blood cultures, chest X-ray normal. And importantly, we did the immunological studies this time. Neutrophil function test or NPT was negative, and it showed more than 95% of neutrophils having normal reactions. So if you can concise this, so a young lady coming with cervical lymphadenopathy, confirmed to be TB from the gene experts and several cultures, starting on ATT. And 4 months into that, she develops axillary lymphadenopathy. And that time also MTB isolated in cultures. Started retreatment regimen. And 7 months into that, she develops left-sided breast lump, which is again seems to be TB and confirmed as TB. So what is the problem with this case? Is the diagnosis correct? Or are we treating something else? Or is there a co-infection? Was the treatment duration was enough? Or the treatment was correct? Was there a resistant type that we could not identify? Or is altogether something else like non-mycobacterium tuberculosis? Or is this an immunological reaction, something we call paradoxical reaction? Or is the patient is having a relapsing remitting type of TB? Or is this an immunodeficient patient like Mendelian susceptibility for mycobacterial tuberculosis, MSMD, if we say it's in short? Or is the delayed type of TB lymphadenopathy resolution, like in delayed sputum conversion in pulmonary TB? So one case, lot of possibilities. With that, let's move on to the basis of my lecture. So today we are talking about a type of EPTB, and globally 15% of all TB cases are in this EPTB category, and TB lymphadenitis is the commonest of them. And isolated peripheral lymphadenopathy is thought to be a reactivation of a disease that was previously inoculated. And in cervical TB cases, it is usually the infection involving the tonsils, adenoids, and Voltaire rings. And this can be a part and parcel of disseminated miliary TB infection, and the clinical manifestations do depend on the immune state of the patient. The lymph nodes are isolated, non-tender, and chronic, and affecting one side. The systemic symptom that the TB patients has is usually, we don't see it in TB lymphadenitis. So because of that, the patients might present even after 12 months of onset of disease. And cervical lymphadenopathy is the commonest. Because these EPTB conditions are post-bacillary, it is very difficult to grow the organism, and it is very difficult to do sensitivity testing, unlike in our patient's case. So pathophysiology-wise, when the TB gets shuttled into the lymph node, the dendritic cells and intestinal lymphocytes activate within around 10 days of post-infection, and they stimulate the adaptive immune response, which contain the organism, either kill the organism or get destroyed by necrosis. So the primary mechanism of killing these bacteria is through the production of cytokines, chemokines, and effector molecules. So ultimately what happens is there are granuloma formations within the lymphocytes. And when we diagnose, more than 50% of the lymphocytes is filled with granulomas. So this is the diagrammatic representation of a granuloma with AFB, acid-fast bacilli inside, with epithelial histiocytes and B cell and T cell cuff. This is the typical of TB granuloma. So what happens to TB lymph node once it infected? Usually they undergo fibrosis, either due to anti-TB drugs we give, or maybe due to the natural resistance. And after calcification, you might see it as even in the chest X-rays known as Hall cell. So it takes around 2 to 3 days for this lymph node to get calcium deposited. And once there's calcium deposition, there's no activity in those lymph nodes. When we talk about the diagnosis of TB, there are tests of definitive tests and there are sets of suggestive tests. So I don't have to tell that TB culture is the gold standard test in diagnosing TB. So does the gene expert and PCR, the important thing is, it does not always say the active infection that I will come into next slide. And you can demonstrate microscopic evidence of TB with acid-fast bacilli. But when we talk about suggestive tests, there are MAN2 tests, TB Gold test, ultrasound scan, CT, MRI, PET-CT. So let me just take one to make an example why we are called suggestive tests. So if you talk about a patient who we do not like, you have very vague symptoms. Symptoms are neither here, neither there. So if you don't think of TB, it's better not to plant a PPT. So once you plant a PPT, now say if that is positive, now don't think that the patient is having TB. Believe me, we get at least 2 to 3 transfers daily, like telling MAN2 positive, please treat for TB. It doesn't work like that. So especially in EPTB cases, these tests has to be taken with the possible pre-test probability. So in a very prevalent TB prevalent country like Sri Lanka, having a MAN2 positivity is not a very good test to diagnose an active infection. So do it if you suspect. There are a lot of false negative causes and false positive causes, like you can go through even in severe infection, even viral infection, recent TB infection, even live vaccination. And in primary or secondary immune deficiencies, you still can get false TB negative. It doesn't exclude TB. False positive can be there in other sort of TB organisms, not mycobacterium, and even in previous BCG vaccination. Well, ultrasound scan is an important tool in diagnosis and even in following of lymph node TB. The first picture to the left side shows the normal structure of lymph node seen through an ultrasound with a normal fatty hilum and a distinct between the lymph node and the surrounding structures. But the second one showing a TB lymph node, which is round, hypercoagulated with surrounding edema and alteration of the fatty hilum. When we take an FNAC, the diagnosis, this has a sensitivity of 88% and a specificity of 96% to diagnose TB lymphadenitis. But the problem is the typical granuloma that you see in TB might not be there when the patient is immunocompromised. And the other thing that again, when you see a granuloma, you can suggest whether this is a TB related, sarcoid related, or other granulomatous vasculitic diseases. So the pathologist would give, they have the patient has granulomatous disease suggestive of TB, sarcoid, or other granulomatous diseases. Well, this is how the TB colonies look like in LJ media. This is the gold standard test of diagnosing TB. The downside of it is that in EPTB, even in lymph node TB, the culture positivity could be as low as 10%. So for that, we have liquid cultures, and it takes about 2 months or 8 weeks for the positivity. But we have liquid cultures now. It can give a negative results within 42 days and a positive results even after 4 days. So this is the newest technology we use for the diagnosis. Molecular studies. So nucleic acid amplification testing. We have 2 types available in Sri Lanka. GeneXpert MTB RIF assays with the sensitivity of 83% and specificity of 93% in diagnosing TB lymphadenitis, which is very low in the pleural fluid. And GeneXpert MTB RIF Ultra, we have it now in NHRD, which has a higher sensitivity, but the specificity is drastically dropping. Let me take an example for that. So if you have a pulmonary TB patient who's a well-built patient with no symptoms suggestive of TB, clear X-ray, if you have ultra-sensitive GeneXpert positivity, you might not even treat the patient because the specificity is low. But the case is different if it is an immunocompromised patient. The other importance is this can detect the rifampicin sensitivity status, so we can change the drugs alternative. And importantly, you cannot use it for serial monitoring. So once you do it, you diagnose TB, see if there's a rifampicin resistant and it's there. So you don't do it for serial monitoring. So don't come in a patient with pulmonary TB or lymph node TB. Even after 6 months, you may still get a lymph node TB GeneXpert positivity. It doesn't mean that the patient is infective or he is still having the disease. It is not for monitoring, only for diagnosis. So what would be the differential diagnosis in sort of a case? For an example, the case we just had. This could be a malignancy, Hodgkin or non-Hodgkin lymphoma, which is very common in young populations. With the TB lymphadenitis is also common. Could also be a non-tuberculous mycobacteria. Could be a sarcoidosis, case of cat scratch disease, fungal infections, bacterial adenitis, Kikuchi's disease, or even SLE. So it is not always straightforward. And believe me, these TB patients might have some other diseases as well. So I have come across 5 or 6 patients who has lymphoma together with TB. So it is not always clear cut that the patient is having TB lymphadenitis. You have to carefully follow up. So this is the updated treatment schedule for TB. In new cases, we give 2 months of HREZD with 4 months of HR. And in any relapse cases, treatment failures, lost to follow-up, we give the retreatment regimen. That is 3 months of HREZD and 5 months of HRE. So in these patients, any place for surgical treatment. So mainly TB treatment is medical, and FNAC is preferred for excision biopsy in most of the cases, because once we do the surgical procedures, there's high chance that the TB comes into skin, forming tracts. So unless it is severely complicated, like non-healing sinus tract or severe disfiguration, surgery is not indicated. And even if we do the surgical excision, it doesn't mean that the disease is cured. So even after that, we have to keep you on 6 months of anti-TB treatment. So why is this mess? Why is suboptimal response in lymph node tuberculosis? Because it can be caused by MOT rather than the TB bacilli. Mycobacterium TB bacilli is more than in the pulmonary circulations. And they have unidentified drug resistance. Why is that? Because we have low culture positivity rates, so the resistant organism might slip by. And poor drug penetration in the lymph node. Believe me, we still use the pulmonary TB data which extrapolate in the management of TB lymphadenitis. So we don't know how much of these drugs go into the lymph node. They might have unfavorable local milieu, and they have enhanced delayed type hypersensitivity reactions than in pulmonary TB. So why is it difficult to treat? One thing, you can't choose a proper drug because the sensitivity patterns are not always available. And even if it is available, it takes 8 months. Now take a bacterial culture becoming positive 2 to 3 days, and we have to wait for 2 months to get the TB sensitivity testing. But in liquid media, we can have it within 42 days, as I said, if it is negative. If it is positive, even after 4 days, we can take. And they have higher number of paradoxical reactions than in pulmonary TB. So even after treatment, 12 to 30%, that means at least 1/3 of patients might have persistent lymph node. So is it reactivation, persistent disease, or just a paradoxical reaction? And they have nasty complications like sinus tract formation. Once it is formed, it's very difficult to treat with drugs. So because of this, there are a lot of controversies for how long we are going to treat. Some say 6 months is enough. Some says no, 9 months to 12 months treatment is given, should be given. And some says if the lymph node is persisting, the recurrence rate is high, so better to treat it. And some says, no, don't treat after 6 months because most of these cases are paradoxical reaction. So we don't have much data into that. So why is this difference? Why pulmonary TB is relatively easier to cure and lymph node TB not? Well, that is because of the differentiation in the cellular levels. The granulomas that we have in pulmonary TB and the lymph node TB is different. Remember the diagram that I showed earlier? There was nice T cells and B cell cuff in pulmonary TB granuloma, which is absent or very less in the lymph node TB. So this is very important to contain the organism, to kill the organism. And this is postulated that this is the reason that the TB lymphadenitis is very difficult to treat. So in this picture, A showing a normal lymph node with normal fatty hilum, and B shows the sparsely facing granulomas. But C shows the nodular enhancement with multiple coalescing non-necrotizing granulomas, and at the last stage, we have multiple coalescing caseous granulomas. But as our patients are too late to present, when they present, it is in the D section. So they have coalescing caseous granuloma. So why does it matter whether they comes in stage B or stage D? So this is about a problem, the penetration of the drugs into lymph nodes. So according to the one and only study that has been done on the drug penetration of TB lymph nodes, so they have studied 2 drugs, rifampicin and isoniazid, and found to have that rifampicin has the highest concentration in blood, followed by tuberculous foci and healthy lung tissue. It has lowest concentration in lymph nodes, and it is even low when the lymph node is caseous. So does the isoniazid, highest concentration in blood, healthy lung tissue, and lowest in the caseous lymph nodes. So if we take in diagrammatical view, so the dark green showed the rifampicin and light green shown the isoniazid. Now see, the lung has fairly enough drug volume to kill the bacteria. Now when compared to caseous lymph node, it is very low. So is it justifiable to give 6 months of same treatment with the same drug types and the dose in TB lymphadenitis? That's the problem we have to address. So monitoring is again a hectic in TB lymphadenitis, but we usually take improvement of symptoms, weight gain more than 5% that is specific, and regression of lymphadenopathy, and serial imaging is better if we have CT PET, but we use ultrasound scan for the monitoring purposes. But why the lymph node size is very difficult to monitor or take it as a universal parameter? The size reduction is different from patient to patient. It is not like in pulmonary TB, sputum positive, we take it 2 weeks to zero conversion and 2 months probably to clear out all the pathogens. But it's not like in lymph node TB, the size reduction is different. And they can persist even after 6 months. So what are we going to do for those patients? And higher number of patients have paradoxical reaction. Or is it really the paradoxical reaction or the recurrence? And you know the lymph nodes are the dustbin. So any disease, any upper respiratory tract infection, any sore throat can cause re-enlargement of the already enlarged lymph nodes. So how are you going to say, assess the lymph node with the size? So there are causes for the worsening lymph nodes during the treatment. The first one that I was talking again and again is paradoxical reaction. This is the most cases of lymph nodes are thought to be enlarged during the treatment, and even after is thought to be for this paradoxical reaction. It is defined by clinical and radiological worsening of pre-existing tuberculous lesions or the development of new lesions in patients receiving anti-tuberculous medications who initially responded to the treatment. It is often self-limiting, and sometimes we have to give steroids, especially in CNS TB cases. Usually, it happens in the beginning of the treatment, but sometimes even after treatment, you can get paradoxical reactions. It has the potential to cause morbidity and even mortality. The exact mechanism is not understood, but thought that there's abnormal immune response or reconstitution of immune system. Because of that, it is more common in HIV co-infected individuals. PR is a diagnosis of exclusion, so you have to exclude drug compliance, drug resistance, progression of the disease, and even secondary infection to say that the patient is having a paradoxical reaction. And most of the time, the worsening are the already persistent lesions. And commonly this happens in CNS cases, followed by pleural diseases, then skin and lymph. The second thing, recurrent after treatment. There are 2 types of recurrence: microbiological recurrence, that is very easy to diagnose. You have recurrence of MTB infection after completion of treatment, but is confirmed by cultures. That is easy. The culture is positive, of course, you have a recurrence. But there's some other category that is called clinical recurrence. In the lack of microbiological evidence, if you have progression of lymph node, you can think of recurrence, but that is after thinking of paradoxical reaction. In paradoxical reaction, you would get resolution even without any intervention. Third and important category is the Mendelian susceptibility to mycobacterial diseases, or where we call it as MSMT. It is a very rare disease, and clinically, these patients predisposed to clinical disease by a weakly virulent microorganisms, like for the BCG vaccination or environmental mycobacteria. The important thing is these individuals are healthy, and there's no overall abnormalities in routine hematological or immunological testing. There's genetic defects affecting the interaction of mononuclear phagocytes and T helper cells that obscure the synthesis and the response to interferon gamma. So because of that, they are usually presenting with a severe adverse reaction related to administration of BCG vaccination. And so patients who have autoimmune diseases, who has autoantibody to interferon, might actually mimic this condition. And they are usually infected with weakly virulent organisms. And in addition, they can have other Herpesviridae family infections like HSV, CMV, and EB. So this is roughly how the TB acts within the cells. So once it is infected with MTB, interleukin cells produce and they stimulate T cells and NK cells to secrete interferons. These interferons activate macrophages to secrete TNF alpha, which kills the microorganism. In these patients where interferon is lacking, you can't produce TNF alpha, which kills the mycobacteria. The usual presentation, this disease is usually diagnosed in children where the patient is presenting with infections to BCG vaccination. But if you don't know this clinical implication, they may be diagnosed as disseminated MTB at birth. So they are infected with non-microbacterial TBs most of the time. And the severity and the onset of disease usually depend on the genetic degree of the defect. And certain genetic particular defects have some other associated symptoms like osteomyelitis. Diagnosis is we have to identify the pathogen and do the immunological testing of flow cytometry, functional testing. And lastly, the genetic mutation identification test. But we don't have all the genetic mutation tests for MSMD types. Approach is just like treating other TB, same drugs, but intensity and the duration is longer. And some may need cytokine replacement with INF gamma. And after the treatment, we better give prophylaxis of azithromycin to prevent further infection. So summarizing everything, if you have a TB lymphadenitis now not responding like in our cases, the first thing, record all the possible sites of involvement and identify coexisting diseases. So I have come across patients who have TB and lymphoma. In the first 2 months, you treat for TB because that was confirmed. And after 3 months, the patient coming with enlarging lymph node, once you do FNAC or excision, it is lymphoma. Now the first treated physician is in trouble. So all the time, if you investigate TB, lymph node TB, do investigate for possible coexisting diseases and treat simultaneously. And most nodes enlarge during the therapy or appears afresh is ultimately respond to treatment. Do not panic. And only the close follow-up is required in this patient. But if the lymph node consistency or something else is different, do give another set of investigation for the diagnosis. And any bacterial infection should be treated concurrently. And non-healing tracts or very large lymph nodes might need resective surgeries. And residual lymph node, even after completion, should be observed closely. And if there's any doubt that you have, you may better go for histology and culture. So most of these patients responded with the same regimen. So in our patient, in the 4th go, she actually resolved all the symptoms. And all the effort should be made to isolate the causative organism. So from where that we do the sensitivity test and further treat. So in HIV patients, you can treat the avium complex as well. The take-home messages that I have for you: do a proper identification of the type of the infection and do the proper drug treatment. Be vigilant in interpretation of worsening lymph node during the treatment. And complete resolution might not achieve even after completion of the treatment, and thus carefully consider the need of retreatment with the aid of microbiological evidence. And do complete evaluation in non-responding cases, including genetic evaluation whenever possible. So thank you very much.